A very warm welcome to today's NITRD-CTD-NTF Difficult to Treat TB clinic. On behalf of NITRD, it is my privilege to welcome all our attendees, including our esteemed Deputy Director General Dr. Urvashi Singh ma'am and Dr. Katoch sir. A very warm welcome. I'm Dr. Neeta Singla, and I look after the Drug Resistant TB Center in my institute. And to my right is Dr. Rupak Singla, consultant in the Department of TB and Respiratory Medicine. On my left is Dr. Saroj. She's a senior pulmonologist at NITRD. To officially begin our section, now I invite our director, Dr. Manpreet Bhalla, to give her address. Is she there? I think due to some technical issue, ma'am has not been able to join. I'm sorry, we are making efforts so that she can join. Meanwhile, I'll request our DDG ma'am, Dr. Urvashi Singh ma'am, to give her opening remarks.
So good afternoon, namaskar to everybody. As always, we are thankful to NITRD, Dr. Singla, Dr. Neeta Singla, Director NITRD, and the whole team to conduct this as a regular activity. We have had some stalwarts in the field of TB from this institute, and we have some experts who continue to guide our guidelines for the National TB program from their experience that the institute, their time and tenure at the institute has contributed to. So we are very thankful for their continued support. The institute, this particular training program, the difficult to treat TB clinic. And what I can appreciate is so many DTOs, STOs have all spared time to join this activity. So obviously this activity continues to contribute to their learning as well. It's it's always something new we carry from these difficult to treat TB clinics. So today I think Dr. Singla sir has brought in a difficult to treat spinal TB case, if I'm correct, sir. So spinal TB per se remains an area where TB specialists would sometimes look forward to expertise from neurosurgeons or orthopedicians. But as we look through the case, maybe all of us can discuss further. I also want to, acknowledge the efforts that the NITRD continues to collaborate with the specialists in other areas, for example, whether neurosurgery, extrapulmonary TB, any other sites. And again, thank you to the team, and we can proceed with the case. Thank you all for joining. And one more thing, NITRD always ensures that the case is presented by an expert from another medical college or a sister institution, which is another very great learning experience from that institution. And it's wonderful to have representation from all over. It further enriches them to deal with their patients. Thank you again.
Thank you so much, ma'am, for your insightful and encouraging words. We are truly honored by your presence in our clinic. It really motivates us and inspires us. Thank you so much, ma'am. Now, moving forward, it is time for our case presentation, which will be delivered by Dr. Sunaina Kharb. She is Assistant Professor in the Department of Respiratory Medicine at BPS Medical College at Sonipat, Haryana. Our state expert for the day is Professor Anand Agarwal. He is head of the Department Respiratory Medicine at BPS Government Medical College, Sonipat, and he is also the Vice Chair of the State Task Force for TB in Haryana. Our national expert who's joining us today is Dr. Sanjeev Nair. He's Professor of Pulmonary Medicine at Government Medical College, Trivandrum. And he is also the Chairman for Zonal Task Force in the South Zone. So a very warm welcome to today's team. And now I would request Dr. Sunaina to go ahead with her case presentation.
A very good afternoon to all. So, I'm starting the case. Can I share my slides?
So Dr. Manpreet Bhalla has joined us. Dr. Sunana, can I take remarks of Dr. Manpreet Bhalla for a minute?
Sure, ma'am.
Thank you. Thank you, Dr. Sunana. Over to you, Dr. Manpreet, ma'am. Dr. Manpreet, ma'am, we are not able to hear you. You need to unmute.
I'm not able.
Yeah.
Yeah, I could not unmute earlier. Yeah. So thank you, Dr. Neeta, and I think already I welcome once again everyone for this difficult to treat TB clinic, which is being held very regularly. And we have Dr. Urvashi has already, we have DTG-TB, and she has given her comments, and we really appreciate her presence and her support. And today we will be discussing a case of spinal TB. And Dr. Singla, this is for the benefit of all the participants. We hold this NITRD difficult to treat TB clinics so that all the participants, the DTOs and other STOs and even the others, all are able to benefit by this from our experts who will give their opinion. And as we all know, spinal TB is difficult. It's one of the challenges, difficult to diagnose, difficult to treat. And so I think we will move forward with our comments from the case presentation and from our experts. Thank you.
Thank you so much, ma'am. Over to you, Dr. Sunela, for the presentation.
A very good afternoon to all. So, let's begin with the today's case. 23-year-old male resident came to us in OPD with a weight loss, loss of appetite, and low-grade fever for last 3 months. After taking further history, he's a student by occupation, Hindu by religion, and belongs to lower socioeconomic status. There was associated loss of appetite, significant weight loss, and generalized body ache with night sweats. There was a history of contact. Mother and his sister had DSTB, for which they took 6 months of treatment. There was no other significant personal history or allergy history, and there was no history of ATT intake in past. On examination, he was conscious to time, place, and person. Height was 167 centimeter. BMI was around 20. He was moderately built and with the moderate poor nourishment, and all the vitals were within normal limit. On respiratory system examination, there was decreased bilateral air entry. Pores crypts were present in the bilateral interscapular area. CVS, CNS, and abdomen examination was within normal limits. On chest X-ray, you can see there was no other significant finding other than bilateral CP angle blunting. On blood investigations, CBC and other blood investigations were within normal limit, except the HB, which was around 8. On sputum CBNAT, MTB was detected, and it was there was rifampicin resistance. It was done on 22nd March 23, and then for further examination, sputum was sent for first-line LP. And on the basis of sputum reports and X-ray findings, shorter regime was started on 22nd March 23. And this was the regime: isoniazid, bedaquiline, levoflox, ethionamide, ethambutol, clofazimine, and pyrazinamide as per weight band. And so he was discharged. On follow-up after 1 month, other symptoms subsided, but he complained of very severe back. And for that, after consultation with the orthopedician, MRI whole spine and CT was advised. CT thorax was advised. So on CT, there were bilateral infiltrates and trine bud appearance shown by the arrow. You can clearly see. And if we see the mediastinal window, you can clearly see here by the black arrow that there is a paraspinal abscess, and there are a few mediastinal lymph nodes shown by a white arrow. So these were the thorax. And on MRI spine, there was altered signal and patch code hypersensitivity at D9 to D12 levels, and there was pre-vertebral collection from D9 to 12 level of approximately 10 into 5 centimeter length of area. And so it showed that there is an infective spondylodiscitis. So in this section of MRI spine, you can clearly see here that there is the enhanced area from D9 to D12, and there is a collection, pre-vertebral collection also seen in these pictures. So these are the MRI pictures. First is with contrast and second is without contrast. Contrast is highlighting the collection and the a lesion at the level of D9 to D12 level in the spine, shown by arrow. So after assessing all the reports, it was confirmed that there is a paraspinal abscess, or we diagnosed with this patient with a port spine after discussing with the orthopedician. And we after discussion, we decided to shift patient from the shorter regime to all oral longer regime because of severe acceptability, with spine. So longer regime was started, and after the during the follow-ups, his back subsided completely, and HB has also improved, which was the only finding during blood investigation, that he was anemic. Now his HB is also normal, 12.6, and patient has gained weight around 4 kgs in these 18 months of treatment. And after present, after 18 months of treatment, there is no clinical symptoms. All the symptoms have subsided, like fever, weight loss, cough, and backache. So these are the culture reports which were sent during the treatment. 2 cultures are negative, and other culture, 3rd, 4th, 5th culture are still pending. But last 2 culture reports are negative, and patient has improved clinically. And the last culture or 3rd culture was sent on 10th of September this year. During the follow-up, this is the chest X-ray of patient, which is showing no significant abnormality other than other than increased bronchovascular marking, which are not very prominent. So there is no angle blunting as it was there in the previous X-ray. On CT, which we see earlier, there was trine bud appearance and infiltrate, specifically in upper lobes. There are no infiltrates or trine bud appearance. So CT is almost normal after the 18 months of treatment. And if we see the mediastinal window of this patient, there is no paraspinal abscess in this picture. And this is the MRI of spine during follow-up after 18 months of treatment. So still there is a lesion, but there is increased signal in the area of D9-D10 level, but there is no paraspinal abscess. It has gone completely after 18 months of treatment. It is shown by the arrow that there is definitely increased sensitivity, or these are the post-treatment changes in the spine. So this is the comparison between the CT before and after treatment. So first picture is before treatment CT. It shows infiltrates and drain bud appearance. And second picture is after treatment film, which is clear, almost clear. And MRI spine before and after treatment, you can clearly see here that there is a collection from the D9 to D12 level and destruction of the this disc in between D9 to D10, but in post-treatment MRI spine, there's no prevertebral collection, and there is a slight increase in intensity only. So these are the post-treatment changes, but almost the lesion has resolved after the treatment. So again, MRI spine showing collection and lesion at the D9 to 12 level before treatment, and after treatment it has gone completely. So these are the point of discussion from this case. In this patient, as we started all oral longer regime without the confirmation of sample, so should we wait for sample to be confirmed that it was a port spine due to MDR TB, or should we start the longer regime on the basis of MRI pictures or CT pictures only? And what should be the criteria for stopping ATT in this patient, and how frequently MRI should be done to assess the lesion or progression of the disease?
Thank you so much, Dr. Sunaina, for your presentation. And almost 150 people have joined after you have started your presentation. So I'll just summarize the case in very short so that other people can catch up on it. This is a young boy of 23 years with history of contact with mother and sister who were treated for DSTB. Patient had bilateral pleural effusion as well as some pulmonary shadows, due to which a CB-NAT was sent, and CB-NAT showed MTB detected and RIF resistance, which was on 22nd March. And based on that, you have started the patient on shorter regimen. And then patient after a month was responding well, but then started complaining about backache, for which you did a CT scan, and on CT you had findings suggestive of paraspinal abscess. So patient was shifted from shorter regime to all oral longer regime, to which patient is responding well. The question that you have asked is that in absence of other reports, was it right to start all oral longer regime? Have I summarized it or have I missed anything?
So, ma'am, we also did MRI to confirm.
Okay. So let us invite questions on the case before I invite our expert, Dr. Anand Agarwal, sir, for his comments. So are there any questions or comments on the history of the patient? Yeah.
So Dr. Sunaina, I have a question. Like we diagnosed this patient on the basis sputum CB-NAT in the beginning of March. So sputum CB-NAT detected MTB. So it was a case of pulmonary TB with extrapulmonary involvement of bilateral pleural effusion. Am I right?
Yes, ma'am.
Yeah. So did we did LPA for this patient?
Sorry, ma'am.
LPA first line, second line LPA.
Yes, ma'am. We sent for sputum for LPA after detecting resistance in CB-NAT. Yes, ma'am. We sent.
You didn't share the report of LPA, so they were sensitive, I assume, right?
Ma'am, because we are not having the report of first line LPA due to some lab issues.
Actually, just wanted to make a comment that LPA, this is Dr. Ritu here. LP in any case, if the sample was being sent, it's not a sputum sample ready. I don't see a reason why LP would be done. Probably first culture would be done and after that only LP. So maybe that's why you didn't get the report.
From beginning of the treatment, we're talking about beginning of the treatment.
Even at the beginning of the
Started
treatment, yeah. So this is an extra pulmonary sample, right?
No,
It
it's
was
sputum.
sputum sample. It was sputum sample. Yeah.
Okay, okay.
Yeah, so I'll take a question from Dr. Rishi also.
Good afternoon, ma'am. This case is very interesting and also quite is also an experience for us all of us. The first case query is the patient had any history of kyphosis or any neurological deficit was there during the history when the patient came to you, ma'am?
No, sir. There was no finding on clinical examination at the time of presentation also, or at the time of beginning itself. There was no clinical symptom or on finding on physical examination. No kyphosis was there.
And any neurological deficit?
There was no.
Paraparesis, paresthesis. Okay.
Thank you, Dr. Sunaina. Dr. Arshad has a question. Dr. Arshad, please unmute yourself.
Excuse me. Yes, ma'am. Actually, I want to ask that whether you have sent the pus for CBNAT as well as for culture to confirm that whether the extrapulmonary site is also because of the MDR bugs or it is due to the sensitive bug.
We didn't send any pus for the culture or CBNAT from the site, from the spinal abscess area.
Okay, Dr. Sanjeev, sir, who's also the national expert for the day. Sir, a question from you.
Yeah, my curiosity in this case is that you have a patient with known contacts. So obviously, when a young boy gets TB, you expect that somebody has passed on the infection to him, disease to him. Now, in that case, both the contacts you have drug sensitive TB, and now you have a patient whom you are not giving any other history of past treatment for TB, and now the patient has come with drug resistant TB. So I feel that in that such a case like that, and we need to look at a few things. One is the two contacts that were there. I mean, were they were the only two contacts, or was there someone else in the family who actually had TB family, or the extended contacts which is now defined in the program? Because either somebody has to have given him MDR TB infection, or he himself should have taken some treatment in the past, which so that he started with the sensitive TB and later became resistant. So these are the only two possibilities in this boy. Either he got infected from somebody who had MDR TB, or he took a treatment wrongly or incorrectly, irregularly, then he developed MDR TB. So we need to review the history of the two contacts very closely, whether they're genuinely cured. I mean, they must have been declared cured, but whether they were genuinely cured. And I mean, in our scenario, I'm sure that you would have reevaluated those contacts, whether they genuinely cured, or is there something, I mean, is there smear still positive? And then this boy also, probably, I'm sure that you took a good history in terms of my curiosity. The other curiosity in this was that you said MTB detected and reflorescence detected, but generally this NAT result always comes in terms of MTB detected very low, medium, or high. I think that part you're not given in your thing, if it has implications. So in this patient, young boy who, if he has never been treated in the past, and if it really had come as MTB detected very low, then we would have rechecked the resistance. Depends on what you actually got on it. If it was, say, high or medium, then you have to go with the resistance pattern. So that is not clear. And in that context, since this boy has not taken treatment in the past, I would doubly be curious on that LPA result, because I mean, in extrapulmonary, obviously you may not get a LPA, but at least in a pulmonary, we should have got a culture and LPA result also. We should have guided treatment. Any comments on that? Thank you for your excellent presentation. I mean, I'm sure I asked a few questions too many, but sorry for that.
Sir, actually, on the part of history, his mother came with him regularly. She's fine, and also his sister. But for the LPA, we have sent from our side, despite of repeated contacts with the lab, we haven't get any reports from them regarding the LP report. And because after we have started longer regime and patient is not expectorating much, so culture reports are also, 2 culture reports are also negative, but there is no result available regarding the LPA.
Was the patient smear positive when you would send it to the lab? Because maybe that's the reason they didn't do LP in the first place. Or they did culture. You just said that it was culture negative. So maybe that is the reason. Just thinking. Because you didn't.
Earlier, he was sputum positive, ma'am.
Sputum
At the
positive at the time of the same sample which was sent to the lab. Was sputum positive?
Yeah, he was sputum positive, and then
Okay.
yeah.
Okay.
Dr. Rishi has raised his hand. Dr. Rishi, you want to ask the question?
No, madam. No, madam.
Okay. Dr. Katot, sir.
Thank you. Actually, I did want to ask in the very beginning, but after hearing the comment of Dr. Sanjeev Nair, my impression is exactly the same. It's very difficult to accept this case as a drug-resistant TB, actually, I tell you. Because the CBNet, a single one positive result, that means your mutants are there, but that microbiologically may not be resistant at all, actually. So I think in the cases where there's no history of the intake or the sources from the likely source from where he got it, they are sensitive. So I think until this was confirmed by the microbiology or by the another molecular test, I will not accept this as a case of drug-resistant TB, actually, to be very frank, because very recently, because I've been chairing that committee in the government and also in the ICMR, when we're comparing the test also. So, the discordance is up the tune of 30%, 33%. And so that much, that high, the discordance with the molecular, the CBNet, I think that question, even the LPA also, I'm telling you, the same type of trouble there. In the initial cases, that where the cases are not treated earlier. So I think that lesson we would like to write someday, some paper, but looking at the multicentric studies, just on the basis of in the initial cases, which are the fresh cases, a single CBNet, I think, is not enough to identify a case as a resistant case, because there is already 30% discordance, more than that. So I think my comment is the same, which I just wanted to add, because Dr. Nair asked a question which I totally endorse his question, and my impression is again the same. Yes. Thank you.
Yes, Dr. Singla.
Yeah, thank you very much, sir, for your comments, especially because it involves the microbiology. You see, again, as we are discussing in this case, patient had contact with 2 persons in the family, but both were said to be drug sensitive TB. We do not know. We need to really see whether they had the CBNet result or not, and whether they were truly drug sensitive or not. They might have been given DSTB treatment, but we are not sure. That is one thing. Secondly, this patient never had cough. As far as the history which is presented, patient did not have cough. Even the X-ray showing only bilateral pleural effusion. He never had taken ATT earlier. So in this scenario, to expect a sputum sample to be positive for LTB and also showing rifampicin resistance, again, as Dr. Katot said, we have to take it with a pinch of salt. So indeed, and never having cough. You see, the reason for a normal X-ray, I'll call it as normal X-ray with only effusion. We don't expect sputum to be positive. Either there is endobronchial lesion. If there is endobronchial lesion, we usually expect patient should be having cough, which, as long as the history, whatever is given to us, it is not there. We also, in these cases, we should look for, we can do the CT scan and see whether there are parenchymal lesions, which are not obviously seen in the X-ray. And this can happen in 20-30% of patients where the X-ray is normal, they are having TB, and the CT scan is abnormal. And third thing is, which Dr. Sanjeev also touched upon, we need to know whether NTB was low, very low, medium, high. Because as per our understanding, we are clinician, and sir can always guide us better. At least if it is MTV very low, a low clinical probability, definitely we have to repeat the test. Even if it is low or it is medium, in that scenario also, the clinical probability in this case is low. So I think before putting the patient on drug resistance TB, we have to be on our guard whether we are on the right lines or not. Rest of the discussion will take later on. Since sir raised this question, so I really wanted to have my comments, and again request sir and Dr. Urvashi ma'am to guide us that in these what is to be done.
Sir, I'll just take one split second. You have summarized that in low, very low, the NAT test per se can go wrong, and there is clear direction that in low, very low load, the ref resistance should not be concluded. It always has to be repeated with a fresh sample. So that message has to get across, because a lot of labs, especially in the private sector, continue to report that, which is against the guidelines. Even if they look at the WHO guidelines, it is clearly mentioned to repeat with a fresh sample. Thank you.
Thank you, ma'am. There's one question. What happened to the pleural effusion? Did it get resolved?
Yeah, ma'am. On follow-up X-ray, there was no effusion.
Okay. Thank you. So, if there are no more questions, then I would request Dr.
I just had one question for the team. If there was no LPA, how did you decide in favor of, even if you considered the NAT test to be conclusive, how did you decide in favor of shorter regimen? Unless you knew quinolone resistance, how did you decide to give the shorter oral?
Dr. Sunaina, would you like to take that question?
Ma'am, because there was very less lesions on chest X-ray, and patient was sputum.
Dr. Sunaina,
CBNet was.
Do you have the CBNet report? Did you share it in the presentation? I may have missed it. We want to know if it was low, very low. So that is the very strong message that gets across. Low, very low, do not trust the resistance result. To decide the shorter oral, you need to know resistance to quinolone. You need to know whether resistance to INH is low level or high level to design your shorter regimen. Unless those two answers are available with you, you cannot decide. So both ways, we would like this message to go that the guidelines have to be adhered to, otherwise we'll get failure in these patients, and we may lose these patients. So the regimen has been, for the sake of simplification, have been given with guidelines that, okay, if this is there, then take this regimen. If this is there, then take this regimen. They cannot be just empirically given on the basis of something like an X-ray. So those are important messages. I have one question for the DTO as well, for the STO Haryana. We had somebody from, why was the LPA not available in this patient? Whether the program people can...
Dr. Anand, sir, would you like to take that question?
Yeah, ma'am. Actually, the two things, I'm listening the case carefully, that this is a case of a young male. So we are concerned that the patient is a young student. We can't do any mistake because life is very precious. Along with that, the one slide which has been shown by Dr. Sunaina, the reports, culture reports, which is displayed on Nikshay ID. So that slide shows that the CBNAT sample has been sent on dated of 5/5/2023, and that shows the result of MTV detected and rifampicin resistance detected. There was nothing has been given related to low, very low, or high, because there is no provision in the format as well as in the form, so that they will provide the report in such a manner that it is very low. There is an indeterminate or there is a detected. These things has been mentioned in the form. So if it is
we'll rectify that in the Nikshay portal. Yeah,
Yeah.
but then why was LPA not looked for and the shorter oral started? That bothers us.
Yeah, and I think Dr. Hitesh will give the answer of this question well. At that time, the Karnal as well as the Rohtak, there are some issue related to the first line LPA because Karnal lab has not, IRL lab has not been fully functional, and they have started the first line LPA in Rohtak also, PGMS Rohtak, but there are some issues which are related to the microbiology department. So the sample has been sent through the Sonipat district hospital, but the reports not retrieved from that place. Besides this, we have tried to send the sample to Delhi also, to the NDTV, but the reports will take time to come. So in meantime, this regime has been started in this case after 1 month of the therapy, because it seems that it is a case of the primary MDR case, and the probability to develop the resistance maybe due to the contact from the society, though history is not very much suggestive because his close contacts having the drug sensitive tuberculosis, but he may catch a drug resistant tuberculosis from the society because at that time hemoglobin was 8 as shown by Dr. Surena. So the probability of immunocompromised condition may be there. Besides this, I just want to ask one question to Dr. Sunena. Is there any history of trauma and all to this patient in the past or just before of this ailment? Can you comment on it, Dr. Sunena?
So no, there was no history of trauma in the past.
Okay. If there is no history of trauma, then chances of catching the infection and entered in this paravertebral gutter may be coincidence, but infiltration is there in the lungs, and patient though not much revealing with the typical features which is shown typically in pulmonary tuberculosis like coughing and production of sputum. But at that time, when the sputum was sent, it was definitely positive. And if it is positive, then as per the guidelines of NTP, the decision which has been taken by the team probably seems right. Though the culture report will confirm, or the first line LPA report will confirm the findings, which is unfortunately not available. The good thing in this case is that once the patient has been put on the regime, symptomatically get benefited, improved of the pulmonary conditions where paravertebral abscess has been resolved. Along with that, the pain in the back as well as the lesions in the paravertebral lesions from the D9 to D12 get also resolved as shown by the MRI report. That is a good thing. Probably at this point of time, you can't say whether it is drug sensitive or drug resistant tuberculosis because not much information in hand, and neither the program support in that direction, because many a times such cases referred to the medical colleges from the periphery and the sample has been sent from that area, and treatment many a times has been started on basis of those reports which actually provided in hand in the OPD by them, and especially once it gets displayed on the NICSHA portal, it is very difficult to discard the report if it shows rifampicin resistance, because many a times it may create a debate among the experts, even if the patient's condition get worse later. So no one can take a risk in such cases where neurological deficiency could be appear if the patient's having the extrapulmonary tuberculosis, especially the spinal tuberculosis. Generally, if it get complicated, it may even cause the paraparesis. So to save the life and the complication of the patients, probably I think the decision which has been taken by the team at that time is appropriate. Along with that, the lesion which are present at paravertebral area is very small, tiny, and that area is very risky. So I am agree with Dr. Sunena that if sample was not taken from that side, because it may cause harm to the nerve roots, and that may also lead to some complications. Probably we are not sure much whether we retrieve the samples adequately from that area to make the diagnosis. So nothing in hand except the sputum report, and on basis of that, we can say there may be the pathophysiology which says that even the direct contact of the effusion which is present in the pleural region may enter in a paravertebral gutter and may cause this Pott's spine, along with the other pathophysiological, etiological reasons like the hematogenous spread or the Batson's plexus spread, or we can say through the lymphatic drainage. But direct contact from the pleural space to the paravertebral gutter may be related with some kind of injury that may occur to the patients and may be responsible to breach that area or break the pleural space so that it give the way to enter the infection in that paravertebral gutter. That's why I'm asking this question to Dr. Sunena. Is there any history of trauma or not? Though this appear within a 1 month, probably one thing which I just want to add as an expert, many a times when we see the x-rays only and we believe that the patient is disease free, is many a times a wrong conception, because costophrenic angle which does not appear in x-rays even, and if we talk about the costophrenic angle as well as the cardiophrenic angles, maybe appear as a pleural thickening. So the X-ray picture or the radiological plain X-ray is not sufficient to give the information about the lesions of the patients. So a patient come positive as a MDR, we always think about for the CT thorax, because many a times we miss the lesions which are present in the in the hidden areas, which is not revealed in X-ray, that actually give the idea about the 60% of the lung portions as per the research. So there is no provision of this CT scan regularly in MDR PMDT guidelines. But the life is important, and we need to diagnose the extrapulmonary cases which are actually missing cases. So I just want to request that it should also be included in the guidelines that if the patient diagnosed as a case of MDR, CCT must be mandatory to reveal the findings which are present in the lungs or even in the extrapulmonary sites, like in the form of pleural effusion or the abscess in the paravertebral gutter. Though the prevalence is low, but every life matters. So I think with this assertion, somehow the team which has been decided the regime may be appropriate. Though this question which has been raised by Dr. Sonena to all of us, if a regime has been started, when we should stop this regime, that is very, very important. So the debate on starting of regime and discontinuation of the regime, both is equally important. If the patient's condition get improved and the decision which has been taken at that time, that is the best decision probably in the on available resources. So now we have to decide when to stop this regime now. That is very, very important. Now I ask to Dr. Nair sir, whether if the regime has been started, what we have to do next after 18 months, whether we should continue the regime as we do with the drug-sensitive tuberculosis cases, where the regime can be prolonged, like we can say for the 9 month, 12 month, or 18 month, the similar strategy will be followed here, or we have to stop it after 18 to 20 months as desired by the NTP program for the pulmonary tuberculosis cases. Thank you.
Thank you, Dr. Anand. Thank you very much for your very valuable comments. So before we go to answer what the question you have raised, Dr. Sanjeev will be definitely taking it up. Before that, just briefly, you see, Dr. Urvashi mentioned a very, very important point, that on what basis the shorter regimen was started. You see, in practice, if we see, this is the usual scenario in the field. There is a suspicion of TB. The CBNAT is done. It says MTB present and rifampicin resistance detected. Now, the clinicians have two choices. One is to start some regimen which is appropriate, and shorter regimen 9 to 11 months is to be chosen when there are three exclusion criteria bacteriologically. One is that the mutation. If INHA mutation present but CATG not present, we can give. If INHA absent but CATG present, we can give. If both INHA and CATG mutations are present, it becomes a contraindication for shorter regimen. Second contraindication bacteriologically is that there is a presence of fluoroquinolone resistance. So ideally, before we start the shorter oral regimen, we should have the INH mutations both and the FQ mutations result with us, so that we know that we are giving a regimen where there is no contraindication. Now let's go to the field. In the field, what happens, like in this case also, and it's not uncommon in the field conditions, that once you have CBNAT result, the probability of having the first NLP result is definitely more. But again, in the field, it takes time, which could vary from 5 days, 7 days, 10 days, easily. And number two is the result of the second-hand LPA. Unfortunately, we are noticing in the country that second-hand LPA result, they are taking anywhere between 1 month, 2 months, 3 months, to sometimes not even available. So now the clinician will have to take a call that once I have a case diagnosed as MTB present and rifampicin resistance present, there are two options with him. One is, okay, you expect the result of LPA first and second line to be available within say 2, 3, 4 weeks. You start on the shorter regimen, and whenever the result is available, you decide whether to continue with the shorter regimen or to go for the longer regimen. Second scenario, the physician knows that is going to take time. Now in this situation, you see it becomes difficult for him to decide, but better is from technical point of view, in case you know that you will not have the second NLP result before 1 month, you have to start on the longer oral regimen. Now the disadvantages. In this scenario, if you have the longer oral regimen, so you have denied the patient the benefit of a shorter regimen of 9 to 11 months, usually 9 months, compared to 18 months of treatment, number one. Second is, suppose at the end of 1.5 months, you have a report which says it is FQ sensitive. Now, technically, if somebody has received longer oral regimen for 1.5 months, this person becomes ineligible for a shorter regimen. The reason being that anybody who's taken more than 1 month of fluoroquinolone is ineligible, or other drugs which are there in the regimen is ineligible for the shorter regimen, unless DST has been documented to be sensitive. So all these things, they come in the picture. So why I'm discussing this point is this is a very, very common scenario in the field conditions, that the LP results are either delayed, very delayed, or they are not available, and the treating physicians, they have to take a call. So these things we have to keep in mind, and the best way, as Dr. Rushi also I think is highlighting repeatedly, make all efforts to change the report. Sometimes it has been seen by the program that the lab is working well. They are putting the report on the NITRD portal, but the treating team, that is medical officer, DTOs, they don't have time or inclination to look at the NITRD and look at the report, what it is. They just start the treatment and forget about it, that the result is to be collected. So always try your best to chase the LP report, to send the sample for LP report, to confirm that the sample has reached the laboratory, also to change the second LP report, and no harm in calling them, calling the lab that it was sent, and please let us know what is the report of the second LPA. And also, of course, we need the capacity building of the laboratories to be improved, that they do it and they do it on time within the turnaround time, which has been, although I feel it is too unrealistic, a 3 days time for the second and LPA, very well knowing it takes time. But still, we need to build up the lab capacity so that they are doing it and they are giving the reports in time. Thank you.
Thank you, Dr. Singla. Over to Dr. Sanjeev Nair for his comments.
Thank you. Thank you for including me in this very interesting discussion. And thank you, Dr. Sunaina, for the excellent presentation. I mean, you brought in a very good case, very interesting for all, and you presented the case very well. Of course, there were lacunae which were beyond your control, where you did not have certain results and all. Now, we are going to discuss the case in detail, but then please don't take it as a kind of criticism. You have done an excellent job, which is reflected in the fact that at the end of your treatment, the patient has responded very well to treatment. So whatever you have done at the end has worked for the patient. But for academic purposes, we'll just go through the case and we'll just discuss that. Dr. Singla has added certain points. I'll just build on that, and then I'll again request Singla sir to add on to whatever I say. So, and from the very beginning, I mean, I made these comments earlier also. I think many of the other experts, including Dr. Urvashi and Dr. Katoch, have actually made the same comment, including Dr. Singla. So the point is that this is a patient in whom we have not been able to elicit a history of tuberculosis ever in the past. So in such a case, who is never been treated for TB in the past, and then you get a result of drug resistance, we need to introspect and analyze on whether there is drug resistance or not. In that context, the most important thing, of course, we all discussed that again, but again, to repeat that, would be to look at the NAT results and look at whether the MTB detected was very low or whatever. Now, Sir had just pointed out that, this was not available on the NICSHI portal. But generally what happens is when such a result comes and when the clinical scenario is there, where this patient has not taken treatment ever in the past, all his contacts are drug-sensitive TB, then obviously from our side, what we do is we immediately make a call to the, the NAT lab obviously would be closer to you rather than the LPA lab. So the NAT lab, it's easier to get a result. Just call up the NAT lab and find out what was the actual result. Can you give out the result in the NAT printout, which often they do. And that actually, if you take the machine printout, it will definitely tell you whether it's, very low or whatever. So you can ask for that particular report. It's within our rights to ask for it. And once you have that report, you can analyze. Same applies to TrueNAT as well. In TrueNAT also, you're supposed to have a value, 10 raised to so much and all that. So if it is like 10 raised to 2 or quite low, then you have to numbers that you get out of the machine and then decide on. Of course, like Sir Dr. Agarwal rightly said, this particular case could have been infected by someone else. Now, we are assuming that there are 2 members in the family who are drug-sensitive TB. And Dr. Singla pointed out that probably, we are not sure. We need to take a proper history and also document review to find out whether the mother and sister actually were tested with a NAT, whether they actually had drug-sensitive TB, or it's just a documentation that this is drug-sensitive TB and let us give DSTB regime. Maybe they got the regime, but maybe not. So that also we need to check. And in today's era, we are also looking at contact tracing, and we are as part of our active case finding, and we are also looking at TB preventive therapy for contacts. So we have an umbrella of contacts to be looked for this particular case as well as the previous 2 cases. So in that, when you have a broad umbrella where you're searching, you might, to our surprise, you might only find somebody who has TB, maybe drug-resistant TB, who is still undiagnosed in the family or in the in the immediate contact list. So that is something that we need to consider. Now, coming on to the diagnosis, now that you have a NAT showing rifampicin resistance detected, let us assume that it is medium or high. So that debate of whether the resistance is there or not goes out. So supposing this is resistance detected on your NAT, of course, we have no other option but to start a drug-resistant TB regime. But there also, I am waiting for my LPA, because the LPA will tell me, reconfirm for me that there is rifampicin resistance. Of course, LPA, I'm looking for other information as well from LPA. But the first thing I'm looking for is my LPA also confirming that this patient has INH and rifampicin, at least the rifampicin resistance. So if that LPA also gives me rifampicin resistance, this whole debate of whether there is resistance or not goes out. And often what happens is there might be discordance when the LPA is done, and then the microbiologist at the lab would actually do a discordance resolution for you. 3rd test would be done, and that way you get a proper result. So in this case, I'm very eager for the LPA, and I would be pestering my microbiologist to find out what actually happened with the LPA. Now, the LPA is also needed for me to decide whether it's a short regime, a long regime, and in this case, we gave the long regime. But even in the longer regime, whether the fluoroquinolone resistance is there, whether I need to modify my longer regime, all those things would be decided by my first line and second line LPA. So even for my regimes, MDR regimes, I need my LPA. So I would be, Dr. Singla also mentioned the same thing. We do make a call to our labs, and we at times even harass our lab technicians and the microbiologists that please give us those results because it is crucial for this particular patient. Now, your first question was whether it's logical to shift to a longer regime. In fact, Dr. Urvashi asked whether it was logical to start the short regime, but then I think I must congratulate your team that I think Professor Agarwal also pointed out that generally in field conditions and even in clinical practice, you miss out on other forms of TB. The moment you get a positive on your sputum, you assume this is TB and start treating without looking for other forms of TB. So suppose even if it was drug sensitive TB, suppose this patient had a sputum positive or a NAT sputum NAT positive result, the fact that the patient also had a spinal TB, even if he was drug sensitive, would mean that he needs a longer regime. So finding out that spinal TB, congratulations to your entire team that you actually worked up the patient very well clinically, and you diagnosed the extrapulmonary TB as well. In fact, this patient has mediastinal nodes, a spinal TB, and maybe TB elsewhere also. So such a complicated case you successfully managed because of your clinical acumen and doing the right investigation. But Professor Agarwal's suggestion on doing a CT for all TB patients, I may not really agree with that, because at the end of the day, we are also looking at catastrophic expenditure for our patients. Often in the government medical colleges and all, this is CT and MRI might be done free for your patients, but a significant percentage of our patients need to pay for these investigations. So if you keep on adding investigations, we would be adding catastrophic expenditure. So if clinically indicated in pulmonary TB or clinically indicated that you are suspecting extrapulmonary TB, we are well justified to do the investigation. But routinely doing this for all patients is something I may not personally agree with. I'll wait for Dr. Sila's comments on that. But then you found out the extrapulmonary TB and you managed well. But there also, I think many of our participants today did come out with a suggestion. And in my clinic, I would have gone to take a sample out of that abscess in the spine, because here there's a debate. We are not very sure about our diagnosis. Maybe the LPA did not yield anything on the sputum. Singla sir pointed out why that LPA probably did not, because there was no cavity in the X-ray and all that. So the spinal pus that you take out, that also would have given you at least a NAT. And if that NAT also came as reflorescent resistance detected, then you have two samples supporting each other, and that would have been good for us. So we would have gone with that and then, manage that particular sample as well. So having diagnosed spinal TB in this patient, now you have to give 1 to 1.5 years of treatment. So that is what our extrapulmonary TB guidelines say, and it applies even for drug-sensitive TB. So anyway, your shorter regime is out because you have a serious form of extrapulmonary TB there. So your first question on whether you're justified in going. So, I mean, there were questions earlier on whether we should have started the short regime in the first place. But having started the short regime, for whatever reason, the moment you diagnose that there is a serious form of extrapulmonary TB like spinal TB present, you have no go but to go with the longer regime, which is what you did rightly. And you went with the longer regime in this particular patient. Now, the next question that you asked is how often will you take a MRI? And to that, my comment is that is clinically indicated. I mean, we cannot say that you take MRI at such and such duration. So it all depends on your clinical acumen. Now, what I would suggest in a patient like this, and what we do at our level, is that at least I work in a college, so we have our core committees and the nodal committees in our colleges, which we encourage in every district. So some of the districts successfully do that. It depends on the resources available in each district. For example, Trivandrum district, where I stay right now, in the district hospital there, they have a cardiologist, they have a nephrologist, they have a gastroenterologist. So, they have riches there, which is unimaginable in many other district hospitals in India. But at least at a medical college, you have a team of people. So when you diagnose a case like this, from the very beginning, I involve the entire team. So the neurologist, the spinal surgeon or orthopedician, the radiologist, very important. The radiologist will also be involved in this particular case and the management from the very beginning, so that towards the end, you know what to do. So even if you take serial MRIs, the problem is that the MRI, often the radiologist will not say whether it is active or not active. Your radiologist is good enough to tell you that this is all healed TB on the, you have some enhancing lesions in the paraspinal region, even in the follow-up MRI. But then, your radiologist probably told you that that's sequelae and maybe that can be ignored. But often what happens is if the radiologist is not fully aware of the picture, what they will say is consistent with TB spine. So at the end of 1 year, you do MRI, it says consistent with TB spine. At the end of 1.5 years, again, it says consistent with TB spine. Then it becomes very difficult for the clinician to decide whether this is active or inactive, or whether to stop or not. So your radiologist also has to be in the picture. They can often do a lot of on MRI to tell you between active disease and inactive disease. We'll not go into details of that because I'm not a radiologist. But the fact is that if you have the radiologist also in the team, particularly in many institutions, now you have interventional radiologists as well. So that actually helps you. Any investigation, now again, investigations are costly. So repeated MRI in a patient, I've seen patients undergoing 6 and 7 MRIs with TB spine, and they paid for it, So it's a lot of money spent by the patient. So any investigation, in my opinion, and I think that is a general opinion, that investigation should be done only if that investigation leads to action. Now, suppose you are doing MRI of the spine, and then you find that there is worsening or no change in the lesion, it should lead to action. The action could be a surgery. The action could be just an aspiration to check for added resistance or amplification of resistance. If at the end of that MRI, all that we are going to do is to continue the same regime, then the whole MRI was wasted. There's no point in taking an MRI. Generally, anyway, one MRI would be needed at the end of treatment to decide that this is healed, and also to keep a record in case this patient has a recurrence or some other symptoms later. But in between, how many MRIs are done would generally be decided by the team. And to avoid catastrophic expenditure, you mentioned that this boy comes from a lower socioeconomic strata. So we would use support from the program to ensure that I'm sure your institution is offering free MRIs, but if it is not there, at least somehow help in doing the MRIs. Financial support is also ensured for the patient. So we'll do that. Now, when do we stop? Again, it's a multidisciplinary decision, and at the end of it's often a clinical decision. Your MRI in this particular case, you're showing very good resolution on the CT of the thorax, as well as the MRI of the spine showing, almost healed lesions. So that's a good idea too. But then wherever possible, you need to take samples for culture. In this case, it may be difficult to get samples from the spine, even though you've done sputum samples for culture. But at the end of the day, it is still a clinical decision. So your team decides based on the fact that the symptoms are resolved, he has gained weight, there are no constitutional symptoms like fever and all that, and the radiological investigations are supporting this patient has responded well to treatment. Maybe a good idea to stop treatment. 1.5 years of a longer regime. I think you started in May, so it's still not 1.5 years. So 1.5 years of a longer regime would be good enough, even though there are certain patients with MDR of the spine who have had much longer treatment as well, which may be individualized in patients. But in this particular case, by the end of 1.5 years, if he has responded so well, that may be good enough for this patient. It's not necessary that you have to prolong for all patients beyond that 1.5 years. So I think it goes on a case-to-case basis. So I think I answered your questions and also summarized some of the other points that came to mind. So thank you, Dr. Singla, sir. Anything further that I missed out on?
Nice.
Thank you, Dr. Sanjeev, for an excellent and complete discussion. And of course, Dr. Agarwal also gave his reasons for having managed the patient the way it was managed, which are quite logical and very practical. Now, I would like to touch on.
Dr. Rupak, I just want to say one thing, just comment on the Dr. Nair's statement, as he says CT scan is not possible in all cases. Though I agree with him, CT scan is not possible in all the cases, but for the MDR cases, we can consider for the same. If it get incorporated in PMDT guidelines, then it will be more feasible for us to make the early diagnosis of extrapulmonary tuberculosis, because extrapulmonary tuberculosis generally are more lethal many a times. So it need immediate action. Otherwise, if it get delayed, there are some complications which may prevail throughout the life. So to keep this in mind, we can add this thing in our program, so that we can give the maximum benefit, optimum benefit to the society. Thank you.
So, Dr. Anand, are you recommending that in all sputum positive drug resistance TB where MDR has been or refractions has been shown, we should do the CT scan? Is that what you mean, or?
Yeah, CT scan, many a times I have observed that in cases where we start the shorter regime, generally the lesions which may be hide behind the shadows of the heart, of the silhouette of the heart, and many a times it is behind the ribs or the clavicle. So the 60% portion revealed, actually, many a times we misdiagnose the case of a simple case or a minor case of MDR tuberculosis, and we start the shorter regime, and we are probably in that condition we are wrong, because we don't think that the patient should go for CT scan first to make the diagnosis. Because if we see the guidelines, not only the isoniazid resistance, but the lesions which matter to put the patient on the shorter as well as longer regime. So in that regard, if CT scan is in hand, we are in a better condition to make the decision whether we have to put the patient on a shorter regime or a longer regime in an initial stage. Though we don't get the first line LPA report in hand, we can take the decision in that regard.
I'll come back to your question. I think Dr. wants to make some comment. Dr. Urvashi, ma'am, please.
So, sir, what I wanted to say is something very simple, and I highlighted yesterday's pediatric TB clinic also, that you see the start of the disease will happen from the pulmonary. We inhale, it's the pulmonary route that. So when this sputum, so the first thing that since we have DTOs, STOs with us here, I want to really stress is why were the household contacts not investigated adequately when the mother and the sister were diagnosed with TB? Second, whether we have that DSTB, DRTB, that debate, again, I had a point to make there. So the first point I want to make is extrapulmonary TB will take time to set in. It's best when you diagnose them early when they're in pulmonary stage. Easiest to treat them. The drug levels will reach well. You talk of extrapulmonary sites, spinal or meningeal or so on and so forth, which could actually, meningeal could lead to 30% mortality. So we need to diagnose early. And here there was clarity that there was contact within the family. The child, the patient should have been investigated well in time. As regards the suggestions that we found earlier, of course, I'm on board that we'll rectify the load, etc. And we'll ensure at least that under the program, very low drug resistance is not reported. Now, as I can see, there are comments that there are delays in LPA culture. We're trying to revamp the whole system, but I would also request all the fraternities sitting here, the DTOs, STOs, to bring to us what are the issues, if at all they're facing in their areas, and we'll try and strengthen the labs in all everywhere where you find issues or delays in your reports reaching you. Thirdly, there was one question which asked about what is the basis of INHA mutation in rolling out the shorter MDR. So if there's INHA mutation, that reflects total resistance to ethionamide, but low level resistance to INH, hence we can give high dose INH. So that is the answer to that question. And one point that I would like to highlight is if we do not diagnose TB early. So if there is subclinical TB or TB that remains chronic, there is a chance that the patient who started with the DSTB may have mutations, that is, the organism may have mutations which lead to resistance to rifampicin. Hence, the chronicity of disease can also lead to drug-resistant TB. Hence, that is one point of view one must keep in mind, that this patient may have started as a DSTB, but since he ignored his illness, comorbidities, of course, as an answer, it was shared later that there was no diabetes, HIV. But do we know whether he was a smoker? Do we know whether he used alcohol? Do we know whether he used substance? So in these populations, we have been recommending bidirectional screening, and we will get it in place hopefully soon. You see, we are aware that, to begin with, we didn't have bidirectional with HIV, then, even to get it rolled out for diabetics who are a known high-risk group, and they worsen rapidly if they get TB, and, the treatment of diabetes is not being taken care of. So risk groups, I want to re-stress, I've been saying this earlier, and all of us, all the experts are saying this. We were not aware earlier the amount of the percentage of TB that is contributed. So all the TB in the country we look at, 46% are low BMI, so that in itself becomes a risk group. We have a major contribution of diabetes, HIV, alcohol, smokers, patients with past TB, patients who are older than 60, and low BMI. So these are the 7 that the prevalence survey also showed us. So in these patients, we must ensure screening, and not only symptom screening, X-ray screening followed by NAT confirmation, at least annually. So I wanted to touch upon these. Of course, the rest has been taken care by Dr. Singla sir, Dr. Nair, and the others on the group. And if there are any further questions, I'm sure the group can take those. Thank you so much for the patience.
Thank you very much, Dr. Urvashi. Coming back to the discussion, you see, in this forum, as Dr. Urvashi also mentioned, Dr. Katur sir also mentioned, this is a forum where we discuss a case and simultaneously we try to give message across that what should be done, what should not be done, why one thing should be done, and these things, and national guidelines also. So now the current discussion, the last discussion was, in case somebody is diagnosed as drug resistance TB, especially like rifampicin resistance TB, should we do the CT scan in all such cases or not? You see, to decide whether shorter regimen or longer regimen, it is a microbiological decision. Only thing CT can help is when we have in doubt whether patient has extensive TB or not. And I think by and large, in these cases, we can see it in the X-ray itself, whether person is having extensive disease or not. And CT scan may not help us much to decide whether patient needs the drug resistance treatment to be given or not given. Second question could be, do we scan the other organs by CT scan? Maybe CNS, maybe spine and other things. I think even in the EPDP guidelines, it is clear there unless you have symptoms. Unless your symptoms suggest you whole particular organ, it may not be possible also, may not be required also to do CT scan or MRI and look for the expected lesions in all cases of drug resistance TB. Now, when we look at the spinal TB, you see, normally in extrapulmonary TB being a possible disease, the chances of drug resistance are less, wherever it is there in the body. But for spinal TB, I was looking through the literature when we were preparing the national guidelines for extrapulmonary TB. In spinal TB, different studies have shown that the prevalence of MDR TB or drug resistance TB is to the tune of 13-14% to up to 30%, which is quite high. So here, that's why it is recommended that in case you have pulmonary TB along with this and the pulmonary TB specimen is showing this is a resistant TB case, you are sort of on a firmer ground that yes, I am dealing with resistant TB. Otherwise, in case you don't have a sample from the sputum, but you have a spinal TB, paraspinal abscess, and you are working in a place like medical college where you have an access to the CT scan or MRI, one should try to take out a sample, subject to histopathology, subject to CBNet, subject to the culture and DST, so that you are trying to rule out the MDR TB in such cases, and you are sure that you are giving the right kind of treatment to the patient. So specifically for spinal TB among all EPTBs, the prevalence of MDR TB being slightly higher than others, one should try to obtain a sample if it is possible. If it is not possible, of course, you will have to take an empirical decision based on the clinical presentation, the X-ray, the CT scan, and other pictures. Like in this case, it was also done. The sputum was having RIF resistance, and there was spinal lesion which was suggestive of TB. So it was decided by the treating team that let us treat the patient as RIF resistance TB with a longer regimen because spinal TB is an indication for the longer regimen. Another thing which I want to highlight is, like if you see the figures, they say for CNS TB, the sensitivity of CBNet is very high to the tune of 80 to 90%. For spinal TB against around 80%. So one should not go with an idea that if I have a case of meningitis, I take out the CSF, in 80-90% of cases my CBNet will be positive. This data in the Cochrane review is of the culture positive specimen. So if there is a CSF meningitis, there is CSF which is culture positive. Among these samples, you can expect CBNet to be positive in 80-90% of cases, not otherwise. So this thing one has to keep in mind when we are evaluating the result of a CBNet in whether spinal TB or CNS TB. Third question which was asked by Dr. Agarwal team was when to do MRI. Again, if you see the EPDP guidelines, it is also mentioned there that first MRI, unless indicated otherwise, should be done around 6 months of treatment. because that is the time you expect significant changes. And they also mentioned that in case you do it earlier, it may give you false sense of persistent of activity or a clinical failure. So in case there is no other indication to do earlier MRI, first should be done at the end of around 6 months. And the third one is at the end of treatment, so that you know whether the disease activity has finished or not. So that the end of treatment will also help you in that direction. And sometimes it is mentioned there also, and that's what the practice nowadays our orthopedic surgeon colleagues are doing, is in case they are not sure whether they are on the right track, patient is responding or not, there are borderline areas, the MRI is also not able to help in this direction, whether I'm heading for a good response or a poor response, they do PET scan. Because PET scan can add on to your information whether my case is still having active disease or not. So they take the ELCO PET scan only in these situations. Routinely, PET scan is not indicated in cases of paraspinal abscess. And you see, the most important point, if you ask me, is we keep on having referrals from the orthopedic surgeon that I've given 3 months or 4 months of treatment, MRI has not improved, please start the MDR-TB treatment. Just they want us to know which drugs and which dosages. So here, it is just 3-4 months of treatment, symptomatically patient is same and MRI has not improved. I think this is not the indication to think in terms of the drug resistance. Of course, we have to ensure the dosages are correct, the compliance of the patient is there, and also in case we feel that these things are not there, we can even do the therapeutic drug monitoring, which is fortunately available with us now. And we have found in many such cases where they were thinking of starting the MDR-TB treatment, we found the levels are very low. So even that thing has to be kept in mind. And I was coming across this Dr. Tulli is the doyen of spinal tuberculosis, and he has very beautifully mentioned in one of his write-ups that when to think of clinical failure of drug resistant TB, it says that if patient has taken 5 months or more of the adequate ATT, and there is a poor clinical and radiological response, appearance of a fresh lesion of osteoarticular tuberculosis, deterioration of spinal deformity, appearance of discharging sinus, or wound dehiscence of the previous operated scar. So what he has mentioned is if these are there and patient has taken more than 5 or 6 months of treatment, definitely you have to move in the direction that you try to rule out the presence of drug resistance TB. So we have to keep these things in mind, that we don't have to miss drug resistance TB. At the same time, we should not be over-diagnosing drug resistance TB. Thank you very much. I finish here.
Thank you, Dr. Singla. Dr. Ritu, you have raised your hand. You want to make a comment?
Yeah, ma'am. Thank you, ma'am. Firstly, thank you for the lucid summary by Dr. Singla sir, my senior and my teacher, Dr. Ushi ma'am, and Dr. Sanjeev Nair. But just one comment I need to make, because repeatedly, some questions have been raised about the delay in the LP reports. I just wanted to, give one thing based on our experience, which can help all the other labs also. Usually, we find the delay happening because the different sample is coming from the CBNAT to the LP lab. There's a different sample. Often that sample, if it is going to be smear negative, it is going to be put for culture. And those reports are either communicated or, not seen in next year. So that gives that thing that, okay, the reports have not come. And that can really delay the right regimen and the right treatment or the right management for the patients. So from an operational point of view, this point really needs to be considered before thinking that what happened to the reports. So that's the small intervention. That's all. Thank you.
Yeah. Thank you, Dr. Ritu. Urvashi ma'am has raised her hand.
I'm sorry, I forgot to. There was a question why are XDR-TB cartridges not being used. So we have got the approval of the NTG. We are working towards it. But in the meantime, let me also inform the audience here, the participants, that there are Indian manufacturers who have come up with NAT, which can diagnose INH much more economically. So we are moving towards that. And also, the Indian manufacturers will bring in fluoroquinoline chips as well. So chips or PCR. So we should have diagnosis of H and FQ resistance at the periphery soon, and we're working towards it. There was a question, so I wanted to address this. Thank you.
Thank you so much, ma'am. And we are so happy that you're going to each and every comment and you are responding to them. We really, really appreciate that. And it also sends a message to all of us, that we can raise our concerns and we are going to get some constructive remarks from CTD and action will be taken on it. So thank you so much, ma'am. And
Thank you. Absolutely. Always.
thank you, ma'am.
Hello. Hello.
Yes, sir.
Me, I'm Dr. Sudesh K. Deravel, calling from Mangalore.
Sure, sir.
Yeah. Now, my point is, or rather, my observation is, post diagnosing spinal TB, we are not giving patients enough care. Like, say, for example, one of my patients, she had spinal TB. She had a fall after that. She was paralyzed, and she was not able to move. And then they undertook a surgery to do some correction, but then that also didn't work out. Initially, it worked out, and she was able to move her legs and things. The point is not that. The point is this: post spinal surgery, they're bedridden, and they develop bed sores. And people who cannot afford are going to stay at home only. So we need to do something to give care to these people, at least from the local primary health center, which is not happening. So these people cannot afford. And if you look into the standard TB care of India, point 23, it states all patients, especially those in vulnerable population group, should be offered free of affordable quality assured diagnostic and treatment service, which should be provided at the location and time so as to minimize workday or school disruption. This lady, she passed away last year. And unfortunately, I feel a bit embarrassed to say this. She said her last word was, "I curse everyone for having not taken care of me. My bed sores are so bad that no one came to do dressing."
Thank you, Dr. Sudesha. Your point is noted, and Urvashi ma'am is listening to it. So let's hope something comes up on this. So since there are no more hand raised and there are no questions, I would just like to summarize what we have discussed today.
Excuse me, ma'am. I have a question, if please allow me. My question is, ma'am, that in these cases, like in primary MDR cases, when all or longer treatment is started, so can we, because all or longer we can modify the regime. So is there any rationale to add drugs like ethambutol and pyrazinamide just to strengthen the regime? Just in this case, patient has an MDR TB and had developed a severe form of extrapulmonary spinal TB. So is there any rationale to add first line medicines? Uh, we do not have the report of isoniazid, but can we add ethambutol and pyrazinamide? And my second question is, like in sputum cases, we do follow up half yearly for 2 years in MDR TB cases. So is there any indication to do something like MRI in this patient for half yearly for 2 years just to see whether the disease is really settled down or there is relapse or recurrence in this case? Thank you.
Thank you, Ankur, for your question. You see, you're coming to your first question, that should we add ethambutol or pyrazinamide in such cases when we are giving longer oral regimen? If you see the longer oral regimen, it consists of 5 drugs. And all these drugs are having good bactericidal action, they have good sterilizing action. Rather, WHO had recommended to start with the 4 drugs and then go down to 3 drugs after 6 to 8 months. But Indian experts took a call to start with 5 drugs. So by themselves, they are good enough to take care of any kind of MDR. If there is a documented report of fluoroquinolone being resistant, we try for higher dose of moxifloxacin if the mutation pattern suggests so. Otherwise, we start going down to the group C drugs. Now, I think what you're pointing is our group C, the order of choice is different than the order what WHO has mentioned in their 22 guidelines. And it was in detail deliberated in the National Technical Expert Group. Should we follow the same order what WHO had mentioned? It says ethambutol as the first drug. If you look at the National Drug Resistance Surveillance among MDR, we are talking about MDR here. Among MDR, almost 45% or more are expected to have ethambutol resistance. Not only that, we are not doing the routine ethambutol resistance DST because of some technical issues. So ethambutol will not be a good drug at all in case we have to add to the MDR-TB treatment as an empirical drug. Even pyrazinamide, the drug resistance surveillance informed that the prevalence of the resistance to pyrazinamide among MDR-TB cases was quite high, 20% to 30%. So again, it is not a good choice unless you have documented sensitivity to pyrazinamide. So keeping a plus, they had mentioned about the imipenem and the logistic constraints of the imipenem, injection being required, very high cost, you require peak line and all that. So keeping these things in mind, the expected resistance in MDR-TB cases, the logistics, the efficacy, the National Technical Expert Group took a call and they have revised the order of choice of the drugs in our national guidelines. So I hope I have answered your first question. Second, I think regarding the MRI, I think we have already discussed. Maybe you missed it. So in the interest of time, I think I may not take that. It has already been discussed. Thank you.
Thank you, Dr. Singla. Dr. Jaikishan sir has raised his hand. So you're muted.
So in the present scenario, what is happening, the weakness of the program is most of the times in case of the spinal TB, the sample is not taken. Okay. And even if the drug resistance is there to the INH or to the rifampicin, the initial response may be there. The patient may feel better. Now, in that type of a scenario, and later on, the patient may say, come with these full-fledged drug-resistant TB. And so in the early stage, we should try to obtain the sample from the site in case of the spinal tuberculosis, 1, 2. And many times our orthopedic colleagues are willing to continue with the treatment even after 18 to 24 months, say, because of the persistence of the symptoms. And the persistence of the symptoms may not be because of the active disease, but can be because of the complications and the sequelae of the TB also. And if the patient continue to have the weight gain and others, despite of the inactivity, the deformity may continue to increase. So here, the role of this education of this the patient not to be at this the weight or to have the assisted devices or at least use that stick or the spinal braces so as to avoid the deterioration of the local sites because of the complications should be there, and we should be taking the help of the physiotherapist and the spinal surgeon to have the correction of the deformity which is causing the symptoms even after the treatment. And the PET, rightly said by Dr. Singla, can be good investigation to say that this is inactive disease. And so in the patient who are having persistence of the symptoms, despite of the full treatment, we should be having the PET scan to rule out the active disease. And once active disease is not there, then we should not be giving unnecessarily the prolonged treatment, and we should be taking care in terms of the rehabilitative part also because of the complications to place. Thank you.
Thank you so much, sir. Dr. Sunaina, I hope all your queries are answered. You have raised some queries, and very methodically, everybody has, tried to answer them. So what message we carry home, I'd like to say to our DTOs first that at the field level, we need to take the proper history. We need to know what happened to the contacts. Then, as our guidelines say, we should be doing all the tests possible and try to collect the reports, that's CBNAT, LPA. This would help us in deciding the regime, whether to give shorter, longer, or if we need to modify the regime. Then, as Dr. Sanjeev and Dr. Singla said, look for other sites of TB. Whenever a patient is diagnosed as TB, try to look for other sites. And if you can get a sample from those sites, try to get a sample and get it tested. Regarding follow-up, if it's extrapulmonary TB and you don't have the facility, then try to have some tie-ups with either private sector or within the government sector, there are provisions in our guidelines which we can do. So this is at the district level. And as soon as you feel that the patient has multidisciplinary issues and there are, extensive diseases, do not hesitate to refer the patient to higher center, that is to your nodal DRTB centers, because most of these nodal DRTB centers would be having the facilities for whatever has been discussed, whether it is the tests or some other tests that need to like MRI or CT. And of course, everybody has said that we should do contact investigation and try to give TPT to all the patients, which is like one of the most important things that we should all remember. And of course, there have been concerns about delayed and non-availability of LPA, and which Urvashi ma'am has very rightly answered. So let us hope we learn from this case and we do better management for our patients. So if there are, do you have any comments?
No.
No, thank you. So Dr. Ashok Bharadwaj has been very patiently waiting and he attends each and every.
Madam, I am enjoying. Nita, I am enjoying. So
In chair of NTF, sir, I really admire your comment.
Nita, I thought this is a very simple case. So it proved to be a very interesting case. So I also improved my knowledge. So here I want to say that from public health view that we must try all efforts to detect or diagnose a TB case as early as possible. Maybe in the periphery, maybe at the district headquarters, maybe at the medical college level. We should try all efforts. Then the comments were by Dr. Rupak and Dr. Sanjeev Nair, excellent. So these are the persons who say they are icon of DRTV in the country. Then Dr. Agarwal. So he mentioned regarding the doing the CT scanning for TB patient. But Dr. Agarwal, I think Haryana is a state where everything is possible and the state will pay for it because there is no dearth of funds for TB in Haryana as far as I know. So you take the case with your state and they will do it. I think Dr. Hitesh Verma is very proactive STO and he can get anything done. So here I also want to say that our new DDG, she can also get anything done. So after a lot of period, we have got DDG, which is proactive and she can get anything done. So please air your grievances or air your deficiencies or whatever you require through your STO, and the Center TV division will take a call and will fulfill all the demands which are required at the field level. So again, a request for DTOs and the STO, please, if some facility is somehow not working due to the civil work, the upgradation, then there should be a plan B so that the patient should not suffer at all. It's the right of the patient to have his diagnosis within no time, whatever the permissible time. Turnaround time, I visited throughout the country, somewhere it is 200 days turnaround time for LPA. So it should not be there. We should link the nearest facility when our other facility they are upgrading or civil work or anything else. So my message to all DTOs: please ensure that the patient do not suffer and hopefully give your demands through your STO to Madam DDG, and I think 100% they will be fulfilled. So thank you very much. Thank you, Nita, for giving me a chance. It was a wonderful discussion today. The case which I thought it is a very simple case. So thank you very much. But one why concern is, to me, the attendance was not satisfactory. It is 50%. Whatever I expected, it increased more than 330. Please ask your colleague to join this important case. So it will enhance their learning, always experience sharing, and it will benefit you academically and in your academically. And thank you very much. Thank you, Nita. Thank you, Rupak.
Thank you very much, sir. Sir, I just want to say one thing, as you have raised the point about the turnaround time. My request to the CTV division as well as to our STO that first, at least minimum first line LPA facility should be given to all medical colleges, especially where DRTV center, nodal center has been established, because it will reduce the turnaround time as well as it will facilitate the diagnosis in a holistic way, because many a times when we send the samples it get delayed or sample may be discarded somewhere due to some discrepancies which not being bring in our knowledge. So if such first line LPA facility will expand at the medical college level where the DRTV center has already been established, it will facilitate the diagnosis also, and of course the management part. It's my suggestion, sir, if it will be taken. Thank you.
So, Dr. Anand, we have more than 91 LPA labs, and medical colleges is where we have placed them. We are working on more such facilities which can provide the essential rifampicin, fluoroquinolone, and INH. We are working earnestly on that, and soon you will see the difference. Thank you.
Thank you, ma'am.
Yeah, Dr. Neeta, can I?
Yeah, sure, Dr. Masi.
Yeah, so I would just like to inform that, as a NRL, we are Haryana is with us, and we are providing all support. And if there are any issues, I think we have already given training for LPA. We have given hands-on training as well as at our on-site trainings. And if any support is required, we are always there to support, but it's a request that they should also, like, once their training has been given, they should actively start doing themselves also. So, but we are ready to support the Haryana state, because we are the NRL looking after Haryana, and we are always supporting them in all possible ways. And if they have any issues or delay, then we can do the LPA for that. Thank you.
Thank you, ma'am. Thank you.
Thank you so much. Thank you to the team who have presented. It takes a lot of guts for the team to take so much questions and criticism. So we really thank our team from Sonipat for presenting the case, and to all the experts, Dr. Sanjeev sir, Dr. Anand, and Dr. Singla, for taking the discussions so well. And of course, Urvashi ma'am, whose presence has, really added to charisma of this program, and Dr. Ashok Bharadwaj sir, as a representative of NTF, and Dr. Katot sir, chairing the NTEG sir. Your presence is really, really appreciated. Thank you so much. And of course to Echo India and Ms. Shifa, who's been supporting this program. So thank you everyone for attending and staying for so long. Thank you.
Thank you all.
Thank you.
Please give your feedback. The feedback form is in your chat box.